So hi everybody. I'm zooming in from Baltimore today. As Al said, I'm a psychiatrist, so I mostly do clinical work, and I research suicide. But I apologize if some of these slides are from talks where it's sort of more aimed at a clinical audience. I'm going to try to skim over the dry parts as much as possible. But I just really wanted to get a chance to talk to you guys. So I know that you're dealing with a particularly vulnerable population as far as suicide risk, and we'll talk about that in a second. Um, so as I go through this talk, I'm happy to answer any questions. I can maybe at the end is better, but even if it's not necessarily about the specifics of this talk, but about suicide more broadly, because you've all had, maybe many of you have had individual experience with residents or in your lives, you might have questions for a suicidologist. So anyway, today I'm going to be mostly talking about lethal means access, which is one of the things we can really intervene on. So I'll quickly go through the epidemiology of suicide. I'll talk about the role of lethal means access, and by that I mean things like having access to firearms or dangerous drugs to overdose on. And then I'll talk about, if there's time, how firearm ownership has really increased, especially in the older population, starting in 2020. And so it's sort of this thing that was already a risk for suicide has gone up more. So suicide has been a leading cause of death in the US for most of the 21st century. This is just by age group. I can say overall, it was the 10th leading cause of death in the US for most of the 21st century, but since COVID, it's been bumped down to 11. It's still a major problem. It's actually rate-wise, or in terms of like the rate of suicide, the numbers are the worst for young people. It's the second leading cause of death for Americans under 40. So it's second only to this unintentional injuries category, which is a combination of like car accidents, overdoses, everything else, and their suicide. But across the lifespan, it's a problem. In 2022, there was almost 50,000 suicides in this country. And that 50,000 number was a bit of a record. This is a figure that just shows the suicide rate in the U.S. starting in 1950. Actually, let me see. Can you see make this into a laser pointer mouse? You guys see this? So these early years, these are sort of decade by decade after World War II. Suicide rate was pretty high, but it had come down starting in 1987. Suicide rate in the U.S. had come down dramatically in 87 until about the year 2000. And maybe coincidentally, that's also when Prozac, the first sort of easy to prescribe antidepressant, hit the market in 87. And we saw suicide rates go down dramatically. But then around the year 2000, they started climbing, and they climbed steadily, throughout the 21st century. In 2019 and then 2020, we saw the first dip in suicide rates that we'd seen basically my adult life. And it's sort of odd because obviously 2020 was not a great year. This was the COVID year and everything like that. And there was a lot of conversation among suicidologists about why that might be. And we can talk about that if you want later. I've got some ideas about it. But nonetheless, we were hopeful that this decline would continue, but it didn't. And then in 2021 and 2022, the numbers went up. In fact, the single largest year-over-year increase in suicide since we've been keeping track happened in this last year of data. And we're now at the highest suicide rate we've ever seen in the US. About 15 people per 100,000 die by suicide each year. Now, suicide can come from a variety of factors. There's not one thing that leads to suicide. It's multifactorial, of course. And I'll go over some list of the risk factors specifically to elderly folks later on in this talk. But I think it's useful to first off recognize that not all risk factors are equal. Some of these risk factors are chronic factors and some acute. And some risk factors are fixed. We can't do anything about them, whereas some we can actually intervene on as people in the lives of vulnerable folks. So things that are immutable or fixed, things like a family history of suicide, that's a risk factor you can't change in someone. There's demographic differences. Being male or white, higher risk for suicide. Having terminal illness, by definition, is unchangeable, but there's a risk for suicide. But there are things we can do. We can address social isolation, especially in living situations. We can address poverty as a society. We can address access to lethal means, we'll talk about today. And then mental illness. Psychiatric illness is one of the most important modifiable risk factors for suicide. Something that we can do by recommending folks access treatment, helping them access treatment, that sort of thing. I say this as a psychiatrist. My day job is treating folks for psychiatric illness. So I sort of am particularly aware of how treatable these illnesses are, but they are a big risk factor. So to put numbers to that, psychological autopsy studies, those are studies that sort of do a post-mortem evaluation of why someone might have died by suicide. I found that 80 to 90% of people who die by suicide have had a psychiatric illness that was a predisposing factor to it. So 80 or 90%, the majority of people. I mentioned before the 14 or 15 per 100,000 number, 14 per 100,000 each year die of suicide. That adds up over the course of a lifetime of years to about 1%. 1% of Americans die by suicide, the general population. Of those that have a mood or anxiety disorder, 5% die. People that have schizophrenia, 1 in 10 people with schizophrenia will die by suicide. And with substance dependence, which is often comorbid with other conditions, the numbers are even higher, as high as 15% of people with serious substance dependence issues, plus minus comorbid other psychiatric stuff, will die by suicide. So it's a major risk factor having any psychiatric illness, one we can address, but maybe not a topic for today. Some more epidemiology just to sort of give you a sense of which demographics are most at risk. Here on the top left, this figure is the suicide rate over the years in men, that's the blue line, and women, black line here. Men tend to have a much higher suicide rate than women. In fact, almost 80% of all suicides are male. There's differences across race and ethnicity. This figure just sort of demonstrates the higher rate in white and indigenous populations. Actually, the CDC has a hard time keeping track of indigenous populations, and so I think they misclassify a lot. But when you look at tribal registries, we see that actually indigenous populations might have a higher rate of suicide than the CDC's presentation of whites. But nonetheless, white and indigenous are the really highest risk groups, although there's risk across the spectrum, especially in Black Americans, where risk has started to climb, especially in the last 2 or 3 years. The largest increases in suicide rates have been in Black Americans, actually a major topic of my particular research. There's also differences across the lifespan. These are age groups. So here's 10 to 14. This is, again, men in this top line, women in this lower line. The risk for suicide changes across the lifespan. So there's a sort of a slightly higher risk period around here, like in your sort of like early middle age. And then the risk, especially for men, goes up dramatically the older you get, up until this 85 plus group, which is by far the highest risk. Interestingly, though, only in men. For women, it starts to decline. But as I said, about 80% of suicides are male. So it's a population that pay a lot of attention. There's difference across the country. I know people are calling in here from all over the US. The darker shaded states here where there's higher rates of suicide, there's sort of this suicide belt in the Midwest. Again, part of this has to do with demographics. As I said, rates are higher in white and indigenous populations, and that's these states. But there's other factors as well, like firearm access. These are sort of heavily armed states. We'll talk about that. But despite how many suicide deaths there are in the US, 50,000 a year, it's still a much smaller number than the suicide attempt rate. People attempt suicide actually quite commonly. This figure, this table, it is divided into young people, high school age, and adults. And this is the past year prevalence. So how many people in the past year self-report that they, for instance, considered suicide seriously? So adults, about 5% of adults report seriously considering suicide in a given year. 1% made a plan. About 0.6% attempt, and then about 0.014, 0.015% actually die by suicide. So it's a small piece of the number of people who attempt. Put it another way, in the US, in a given year, we'll see about 1.5 million adults attempt suicide in the US each year. 1.5 million attempts. Of those, about 500,000 are admitted to the hospital for the attempt, which might be a way of saying how sort of severe the attempt was. And yet only this small sliver of about 50,000 people die by suicide. So what's that about? How does people survive? A lot of it has to do with the method used in the attempt. Some methods are more lethal than others, obviously. I think one of the clues we have is something that I think every medical student is a little bit baffled by. As first year medical school, one of the things we learn about suicide is that women tend to attempt suicide much more often than men. Women tend to attempt suicide about 2 or 3 times as often as men. But men have 3 or 4 times the suicide death rate. As I said, they make up 80% of suicide. So what's that about? Well, men and women tend to have access to different sorts of methods and tend to use different methods. This figure, this table on the right from Connor in 2019, it's actually a replication of a CDC study. They replicate every couple of years. All shows the same thing. Connor looked at the last 4 million suicide attempts in the country from CDC data. So looked at all the suicide attempts. I think his data set was 2007 through 2014. They had well-characterized attempts. But 4 million attempts. Of those attempts, about 300,000 people died. That's about an 8% fatality rate. But the difference between methods is really dramatic. So poisoning, that's overdose. That might be opiates or Tylenol or sleeping pills. Overdose, poisoning, suicide attempts are by far the most common. More than half of the attempts were by poisoning, 2 million by poisoning. And yet, only 43,000 people died. Poisoning only has about a 2% fatality rate. Whereas firearms, only about 5 or 6% of the attempts were by firearm, only about 175,000. But of those 157,000, 90% died. And so the method used here is the major the deciding factor between whether someone lives or dies, essentially. If a firearm is used, it tends to be fatal. If there's no firearm available, they tend to be survived, but people see treatment. And we'll talk about what happens after someone's been. But because of that, firearms are, even though they're only 5 or 6% of attempts, they make up the majority of suicide deaths in this country. That's by far the number one cause of suicide death. The second leading is suffocation, which is hanging, at 26% of suicides. But I don't think I'm more than half. In fact, when we're talking about firearm death, we're often talking about things like mass shootings or interpersonal homicide. But suicides are actually the most common type of firearm death in this country. About 60% of all firearm deaths in the US are suicide. For older people, it's a little bit more dramatic. Among people 65 to 74, 68% of all suicide deaths are firearm. And for those over 75, almost 80% of all suicides are violent. So it's an important factor. It's an important method of death. We have all these risk factors, right? We have genetic risk factors for suicide, psychiatric disease, personality factors, stress, chronic pain, terminal illness, a million risk factors. But all of these things sort of go through this complicated diagram Keith Houghton put together to come to this point where an attempt is made. And that attempt either results in suicide death, becoming one of those 49, 50,000 people who die by suicide, or a self-harm attempt that survived, an attempt that survived, and treatment can be sought. And the only real thing that distinguishes between whether this event leads to death or a survived attempt is whether the method was used was a lethal one. And so it's important to think about the choice of method. And it turns out the choice of method is essentially a consequence of just what methods are available to that person when that suicidal impulse strikes. And actually, to understand that, it's important to recognize how impulsive suicide can be, because I think in the media, it's often presented as this sort of, journey where people, are thinking about suicide and they sort of might make a complicated plan, run a bath, write a note, that kind of thing. In practice, when you look at actual death data, that's not generally how things pan out. It tends to be a lot more impulsive. This is a study that's a good example of the impulsivity of suicide. This team of mental health workers, led by Dr. Simon, interviewed 153 people who had made high lethality suicide attempts, so attempts that were likely to result in death, but they survived, and found that when they interviewed them, most of them had only decided to make the attempt very soon before actually attempting. So this would have been an interview like this. They would have said, these are people in the hospital after an attempt. They said, okay, I know you might have been depressed for a while. You might have been thinking about suicide. It's been on your mind. But how much time passed between the decision to act, saying, you know what, I can't do this anymore. I can't deal with this psychic pain or this literal pain. Can't do this anymore. I would rather be dead. I'm going to do it. How much time passed between that decision and the act of the suicide? So 87% of folks they interviewed said it was within 24 hours, same day. In fact, about 71% said it was within an hour. A quarter of them said it was less than 5 minutes. There's 5 minutes passed between me deciding to do it and doing it. So what that tells you is people are getting to this very quickly and acting very quickly after the decision. And it tells you that the method used then is going to be what's available. So if this decision, someone's lying in bed, it's 2 a.m, they can't sleep, and the ambivalence resolves and they make this act. If what's in the bedside table is a bottle of sleeping pills or Tylenol or something, and they overdose on that, thankfully, that only has a 2% fatality rate, like I just talked about. So 98% of the time they'll survive, and they'll get treatment up with that. But if what's in the bedside table is something more lethal, like firearm or very powerful narcotics, and that's what they'll use, and their chance of survival is much. Said only about 10% of people survive a fire. So that when we ask the question, who uses a gun for suicide, it really comes down to people that have the gun. They use a gun if they have a gun. This is 2 different maps. On the left here is a map of firearm suicide rates across states. Remember, I showed you a similar map that was suicide rate in general. This is specifically firearm suicide rate. See, it's not too dissimilar. The darker states have a higher firearm suicide rate. Over here in purple are the states shaded by the proportion of households that own guns. So like in Montana, Wyoming, Idaho, about half of all households have a gun, much less in like Ohio or in New York. The higher the proportion of gun ownership, the higher the rate of suicide. You can see you sort of compare these maps just visually. We can also look at it more scientifically. And here's where I don't want to get too dry into the data, but I really like this study that Matt Miller did in this table here. Matt Miller is a researcher up at Harvard. He took the country and divided it into areas that have high gun ownership and areas that have low gun ownership. So if you look at this table, these are the high gun ownership MSAs, metropolitan statistical areas of the country, cities, and then low gun ownership areas. So he divided it into 500 million person years in each. In high gun areas, we're talking about 34% on average of households have firearms. Low gun areas, about 11% have firearms. And he compared those two areas' suicide rates, controlling for all the other things that might affect. So controlling for demographics, controlling for proportion of people that are veterans, which is a suicide risk factor, controlling for alcohol use, controlling for access to mental health care, other things that might affect suicide rate. Comparing those things, he found that compared to low gun areas, high gun areas had 2.4 times the firearm suicide rate of low gun areas. Now, non-firearm suicide rate was equal, 1 to 1. 1.0 is the odds ratio, because he controlled for all those sort of things. But because so many suicides are by firearm, then the total suicide rate was 1.5 times or 50% higher in high gun areas compared to low gun areas. The difference was even more extreme for kids, but we won't get into that. Another study looked at individual firearm access, not just the prevalence of household firearms, and found that for individuals that have access to a gun, they have about 3 times the risk of suicide, disregarding everything else. Just general population, if you have a gun, you're 3 times more likely to die by suicide, regardless of whether you have depression or whether you're suicidal, anything like that. Other studies have found, Danielle Steele-Smith did a great study a couple years ago, that in urban counties, for every 1 additional gun shop in the county, there's a 1% increase in suicide. You add 10 gun shops to your county, 10% increase in suicides across the board, not just firearm suicides, led by firearm suicides, but the suicide rate just goes up. So often when I talk about this, the first question that someone might ask, that I'll preempt here, is this idea of, well, if we just take away the lethal method, firearm, whatever the immediate lethal method in that culture is, will people just find some other way to die by suicide if they're suicidal? And this is a commonly held idea. In fact, Matt Miller, who did that previous study I mentioned, did a survey study 15 years ago, surveying Americans, just general population American, asking if someone was about to jump off the Golden Gate Bridge, but they were stopped somehow, they were pulled off the bridge, would they just find some other way to complete suicide? And what he found was 3/4 of Americans said, yeah. 74% of Americans said, yeah, if you stop them, most or all potential jumpers would find some other way. If they decided to die by suicide, they will. Amy Best repeated that study with ER doctors and had something similar. But the reason that Matt had looked at Golden Gate Bridge jumpers in his hypothetical survey is that that's a well-studied phenomenon. You might know the Golden Gate Bridge is a very popular suicide spot in the US, San Francisco especially. And it's been studied. So Cited in 1978 did a huge study of Golden Gate Bridge jumpers. He identified 515 people who had either attempted to jump off the Golden Gate Bridge and survived the fall. So about 1% of people who jump from that bridge do survive. Mostly it's fatal, but 1% will survive. Or had been physically pulled off or got caught in the scaffolding when they fell, just basically survived, which should have been a very lethal attempt. He found 500 people that met those criteria and then followed them. He followed them for a median of 26 years, a very long study, the kind I can't get funded for these days. But he followed them for 26 years and found that of those 515 people, less than 5% of them ever went on to reattempt and die by suicide. And those that did, it was pretty quickly right after that surviving attempt. They were pulled off and they quickly found some other way. But it was less than 5%. So 95% of survivors just keep on surviving. Another study that looked at something similar, O'Donnell in the 90s, looked at about 100 people that had jumped in front of the subway in London, the tube system in London. Again, high lethality method. That's a very deadly suicide attempt method, jumping in front of the subway. But you can like fall between the rails and the train can pass over you, that kind of thing, and you can survive. So he found 94 people that had survived, followed them for a decade, and found that less than 10% of them ever reattempted and died by suicide. There's a meta-analysis that looked at lots of studies like this, and it turns out that if you average all these studies together, it's 4 to 6% of people who survive a serious attempt go on to later die. 95% just keep on surviving. So if you survive that first attempt, the chance of dying by suicide, it's not very likely. Part of that is reflected in the fact that the majority of suicide deaths in this country and across the world are first-time attempts. Most people who die by suicide, that was their first attempt. And in fact, most people who die by suicide have never reported any suicidal ideation to anyone. It's a very hard thing to predict because of that. And that's why some of these public health methods like gun access be more effective even than what I do, which is treating depression. Because most of these people who die by suicide never came to see someone. They died before any care was done. So then what happens then if that's the case, if suicide is impulsive and lethal methods mean death? What happens when we take away a particularly popular, lethal, convenient method of suicide? There's been some natural experiments with that. In the UK, for a long time, one common method of suicide was carbon monoxide poisoning. Oh, sorry, I looked over to the chat that's in my side window, and I saw what Jenny said about a Golden Gate Bridge jump survivor. I wonder if that was Kevin Hines. He does a lot of interviews, and he says exactly that. As soon as you jump, and I've heard that from patients who've made attempts. As soon as as the attempt is made, all of a sudden, all those problems that were, leading to the suicidality seem to be dwarfed by the fact that you're falling off the Golden Gate Bridge, and it really puts things in perspective. So maybe there's a catharsis to it. But for other people, it's just the impulse does. Anyway, so back to so in the UK, there was this method of suicide where people put their head in the oven. So famously, Sylvia Plath, the writer, died this way because the ovens were powered by coal gas, which produces carbon monoxide. It's very poisonous, and everyone had an oven. So you would just blow out the pilot light, and the coal gas, the carbon monoxide producing gas, that powered the oven, would be poisoned. Die. In the UK in the 70s, 60s, and 70s, they switched from coal gas ovens to natural gas ovens, not to prevent suicide, but just for economic reasons. They switched over from coal gas after that. But a side effect of that is that natural gas methane is not fatal. And so people couldn't just use this method. Freitman, a scientist that followed this, followed the rollout of conversion from coal gas to natural gas. Across the UK, this figure here is the proportion of ovens using carbon monoxide producing coal gas went down until 1975. No ovens used that. It's all natural. And at the same time, followed the suicide rate in men and women. This is the carbon monoxide, that's CO, carbon monoxide suicide rate in men. As the ovens switch to natural gas, the carbon monoxide suicide rate goes down, not to nothing, but much farther down. The reason not to nothing is there's other ways to die by carbon monoxide poisoning. For instance, before modern carburetors, you could put a hose from the car exhaust pipe into the window of the car, and suffocate carbon monoxide that way. That won't work these days. But that's complicated. You have to get a hose, you got to tape it up, you got to stretch it to the window, and seal the window up around the hose. All those things take more than a few minutes, and that impulse passes. And so there wasn't a replacement with that method. There also wasn't a replacement with other methods. These are non-carbon monoxide poisoning suicides, other types of suicides, guns, hangings, that kind of thing. They didn't really change significantly, stayed about the same. And so the total suicide rate in men dropped and stayed down. In women, there was maybe a little bit of replacement with other methods, a little bit of a switch to hanging, but not enough to offset the lives saved. The total suicide rate goes down. In other places, it's other things. It's going to talk about a couple more places. In Sri Lanka. Sri Lanka is an agricultural economy. We see this in a lot of these agricultural countries. There's a lot of pesticides because it's part of, farming. And so if your country is powered by farming, you have a lot of pesticides and herbicides. Pesticide poisoning was by far the most common method of suicide in Sri Lanka. This figure here is, the blue line is the pesticide poisoning rate in Sri Lanka over 30 years. This is every other method. So like hanging is by far the second leading, distant second to poisoning. Other things like burning or shooting or cutting, they're dwarfed by the poison. In Sri Lanka, in the 80s, they banned some carcinogenic poisons. Didn't really affect suicide. These were just carcinogenic, not fatal in overdose. But in 95, they banned all class 1 pesticides. These are pesticides that are very easily fatal in overdose. I've treated organophosphate poison a few times. It's a terrible way to die, but it's a very fatal way to die. They banned these pesticides in the country. The suicide rate by pesticide went down dramatically. Here, they banned one more type of fatal pesticide. It kept going down. Suicide rates by poisoning dropped, with maybe a slight bit of replacement, people using a different method, like hanging here, but only a small portion of those people. Overall, the ban resulted in a suicide rate overall that was cut by half and stayed down. This taking away a lethal, accessible method for suicide. Similarly, in the UK, back to the UK, there was also a problem with suicides by paracetamol overdose. Paracetamol, it's Tylenol. It's the word they use for Tylenol, basically, for acetaminophen. It's an over-the-counter headache drug. And people would overdose on this. As I said, they usually survive, but people do die from these poisoning. So Parliament in the UK passed a few laws to prevent suicide, to make it so that if you were to buy paracetamol, Tylenol, in any amount more than 16 tablets, it would come in that bubble wrap stuff. You got to get your fingernail in there to pop the pill out of this stuff. As opposed to, here we can go to Costco, buy a tub of Tylenol. But there, they switched it so you had to get in this bubble wrap stuff. So if you wanted to overdose, you had to sit there and pop out every one of these pills, which doesn't take very long. If you imagine popping out a couple dozen pills, maybe 5 minutes or a few minutes, not a long time, but enough time that that impulse was passing for people, significantly enough that this resulted in a suicide drop in the UK by poisoning suicide by 22%, a fifth of suicides prevented just by doing this sort of thing. There's some Israel data too, but I want to skip ahead. In the US, though, it's guns. In the US, guns are the lethal, convenient, accessible way of suicide here. And so every regulation we've passed that's addressed gun access has resulted in, on a public health level, a suicide drop. So when DC started requiring gun licensing in the 70s, firearm suicides dropped by 23% right off the bat, with no replacement to other methods. Other methods didn't go up. Dan Webster here at Hopkins looked at child access prevention laws. Not as relevant for this audience, but these are laws that make it so that if you have a kid in the house, then the gun in the house must be stored locked up. These laws exist in most states, but not all. But passing those laws resulted in a suicide rate decrease in teens by about 8%. Mike and Nestadt and Joy and Nestadt, who were in Mississippi, now they're in Jersey, looked at individual laws that required guns to be stored safely or required background checks, restrictions to open carry, just basically barriers to gun ownership, and found that each law that passed decreased suicide significantly. And then Kaufman, who was actually a surgery resident when she wrote this study, looked at a composite score of just how strict the gun laws were in a given state, and found that the stricter the gun laws were, the less suicides and homicides there were in that state, controlling for everything else. Specifically, in sort of permissive gun states, the suicide rate was 20% higher. So in sort of stricter gun states, the suicide rate was 20% lower than in high gun states. Actually, the homicide rate also changed. That's not really. I want to talk a little bit about elder suicide specifically, for this audience especially. I mentioned before that suicide rates do correlate with age, right? So there's a kind of a high rate in that 15 to 24-year-old range. Actually, I'll point out that rate, the sort of 15 to 24, is particularly the highest rate in Black populations and Indigenous populations. It's not as much of a peak in white, Asian, or Hispanic population, but that younger rate is a real issue in many people of color. There is a higher rate in middle age, so around age 50, especially in white non-Hispanics in the U.S., whether male or female. But the highest rate is this 70 plus, the sort of like mid-old to old age groups. And as I pointed out before, that's actually unique to men. For whatever reason, older men are really at incredibly high risk for suicide. Now, older men are also, and older women are also at much higher risk for other causes of death, of course, like heart attacks, cancer, these sorts of things, strokes, are much more likely at older ages than these like 15 to 24-year-olds, obviously. So that's where it becomes important to recognize the difference between the rate of suicide and the actual number of suicides, right? So here's the rate and the number of suicides across the lifespan. The blue dotted line is the suicide rate. So when you get to these older age groups, the rate is very high, even though the number is low because they're dying of other things, right? So the number of suicides is low because there's less over 85-year-olds. Not everyone makes it to that age, right? So if you died by something else, you're not part of the denominator here. But among those that are still alive at age 85, the suicide rate is tremendous. I'm in Maryland, so this is just my data. I work with a medical examiner in Maryland. So this is just the most up-to-date data in Maryland. These are suicide rates by age group in my state per 100,000. So you see like this peak I mentioned before around age 50, this little peak in this younger group. But again, the highest rates by far, as color-coded here, are these older groups, 75, 80, 85. Now, the risk factors for suicide in older adults they're not so different than the risk factors across the lifespan. But I also want to sort of highlight a few of them for you folks. And I do want to also say, none of these things are, slam dunks. It's not like everyone with psychiatric illness is going to die by suicide. As I said, it's like maybe 5 to 10% depending on the illness. But it is a risk factor. So psychiatric illness, substance abuse is a major risk factor for suicide, especially in an older population. Actually, my next 2 slides are about that specifically. I'm going to very much be cautious of. Gun ownership, I've been talking about. Chronic physical illness, especially disabling illness, terminal illness, or chronic pain illnesses are major risk factors. I'm sure ones that you're very familiar with in the populations you work with. Recent onset of dementia, I'm going to talk about in a little more detail as a major risk factor. Grief, loss, bereavement, common in this age group, of course, especially people lose their spouses. Being a victim of ongoing violence or abuse, social isolation, homelessness, lack of engaging or meaningful activity is actually a major risk factor. It's amazing. Loneliness, as it's quantified by the WHO, is actually almost as much of a risk factor as things like alcohol dependence. And something that, in your populations can be addressed. Prior suicide attempts, as I mentioned, is a risk factor, although the majority of suicide decedents have never previously. Family or spousal history of suicide and a history of childhood. How much I want to talk about the substance part, other than to say, yeah, there's a lot of data here. Let me just say, in the past, alcohol use was seen as more of a young person issue with suicide. So this is Maryland data, it's my own data. In Maryland, 24% of people under 65 were intoxicated on alcohol level over 0.08 at time of death. So about a quarter of people were drunk when they died by suicide, whereas for over 65, it was only 9%. However, this has been a trend that's changing. So this is a paper I had that came out in 2020, looking at the proportion of elderly suicide decedents who had alcohol in their system, over 0.08 alcohol in their system. In 2007, it was down at 5%, but it's been just growing and growing, so that by 2019, 1 in 5 geriatric suicide cases were alcohol is becoming more and more of an issue. And the same for opiates. Opiates are obviously a growing problem across the lifespan in the US. But again, there was this dramatic increase, especially the green line here is the over 65-year-olds. The over 65-year-olds have had a steady increase, even more than younger people. The proportion of people who are using opiates who die of suicide, up to 21% of geriatric suicide decedents in 2020, compared to only 5% back in 2000.
Dr. Nestadt, can I interrupt you for one moment? I just had a question about that slide.
Yeah, go ahead.
How does, and maybe this is really getting into the weeds, but I'm just curious, how is it determined if someone accidentally overdosed or purposefully overdosed?
So my main research is in that question. That's what what's called a K award. The NIH funds me specifically to answer that question because it's not easy to do. And it varies from state to state. And I don't want to maybe spend too much time because I can talk forever on this, but the bottom line is it's not easy to do. Some things, sometimes it's obvious, like if there's a suicide note left, okay, so that's about 25% of suicide cases have a note. And then it makes the medical examiner or coroner's job very easy. But in other cases, that's not the case. And so it varies from state to state. In general, in the US, 8% of overdose deaths are left as undetermined. We don't know if it was an accident or a suicide. 8%. In Maryland, we're an outlier. That's why I study it here. In Maryland, 80% of the deaths, overdose deaths, are left under. We just don't know. So my research, I do something called psychological autopsy. I go back and I interview family members. I go through medical records. I dig in as much as I can to figure out, what it could be, so that and I work with a medical examiner here to see if there's sort of clues they can use for other cases that don't have that much resource to look into. And we use machine learning algorithms, things like that, to determine it. But often we can't tell. It's from interviews with family, and there's clearly a spectrum of intent. There are people that are using, heroin, fentanyl, these narcotics that are very dangerous, that might not, want to die, but maybe are a little bit more reckless or ambivalent about whether they live or die. I work inpatient, where I work with what's called a dual diagnosis population, people that have both a substance use and other psychiatric illness. And there's often this sort of like ambivalence, like yeah, I didn't really want to die, but I wouldn't have cared if I did, that kind of. So that's a complicating part as well. And then there's fentanyl, which has made general use of heroin in the community a lot more deadly. And so people that really had no intention of dying. So it's hard to say. But we're getting better and better at it. Currently, my data is showing that about a third of people that are left undetermined in the states I've studied, Utah, Maryland, Michigan, California, are in fact likely suicides and being misclassified. So this data is all people that medical examiner was sure it was a suicide. But like I said, about 80% they say we're not sure. About 15% they say this was an accident. And then like 5% left, they're the ones we're sure this is a suicide. Of those, these are the people that are positive for those drugs. I don't know if that's a good answer. But yeah, it's hard to say. And it matters also if your state uses medical examiners instead of coroners, which is a whole.
It sounds like I opened a can of worms, but thank you for
Yeah,
touching on that.
That's my main research. So I'm here talking about guns, but opiates are what I mostly talk about.
Why is it so much higher in Maryland? You said it was 80%?
Yeah, and there's some politics to that. There was a medical examiner in the 90s, a guy named Dr. Smiley, that sort of set a tone. Maryland had been sort of like the gold standard for medical examiners for most of our history. Actually, Maryland has the first statewide medical examiner's office in the country. Now other states do it. But we sort of like our chief medical examiners had been the presidents of the National Association of Medical Examiners many years in a row. We were like the one. And maybe because of that, they never wanted to be wrong. So instead of saying this is probably a suicide, this is probably an accident, they said undetermined. We're not sure. And that is changing now, interestingly enough, because of the George Floyd murder. It's sort of like there was one of our medical examiners got pulled in as an expert witness and kind of put his foot in his mouth. It's a long story, but like we're changing in Maryland now, getting better at figuring out who's actually a suicide and who's not, based on some political stuff. And that's what I'm helping with. But it's still a hard question to answer, whether someone's suicide or accident when it's an overdose. And actually, I lost a patient to suicide last week. And incredibly, given the severity of the population I treat, this was the first time I'd ever lost someone to suicide. It happens. We treat an ill population. And this woman who died by suicide was an inpatient of mine we discharged a few months before. I know the medical examiner was actually calling her death an accident. And it was clearly a suicide. I mean, she was in the hospital after a serious suicide attempt, and was actively suicidal for a very long time, and had actually called her 8-year-old son to say goodbye. It was clearly a suicide, but the medical examiner, for complicated reasons, called it an accident. So there's lots of politics and policy reasons why people go one way or the other, but it's not always accurate. And that's something we have to keep in mind with all this data, all the data we talk about across science. It's only as good as the people making the call. Anyway, so in Maryland, just sort of back to guns. This is Maryland data, but I think it's really representative of the US data, and I'll talk about that in a second. This is the total suicide methods in Maryland for people that are over 65 versus under 65. This is from 2003 to 2022. It's all medical examiner data. So firearms make up about 41% of, I guess, younger than 65 suicides in Maryland, but a much higher number of the older than 65. And part of that, Maryland, remember, actually is very left-leaning state. So we have relatively strict gun laws, and we have relatively low gun ownership compared to other states. So that's why these numbers look smaller than national. With male suicides, men over 65, it was 73% of all of the suicide deaths were by fire. it's a major issue, especially because firearm use and access is going up. Right now, about a third of Americans over 65 own a gun, and an additional 12% live with somebody who owns a gun. They have access to that. So we'll talk about that actually, especially when we're talking about folks who have dementia diagnosis. The dementia, obviously, an affliction much more common in geriatric population. And it's one of the major risk factors for suicide in this population, especially early in the diagnosis, right? So you guys have residents that have some mild cognitive impairment. Probably many of you have residents that have very severe cognitive impairment. I guess as long as they can still sort of live in an unsupervised way. But it's maybe counterintuitive to note that the less severe the dementia, the higher the risk of suicide. And part of that might be that just being given that diagnosis is a shock, is a stressor, obviously. Being told you have what's essentially a terminal illness that's never going to get better. That period at the beginning of the diagnosis may be high stress. It also might be due to the fact that people with more advanced dementia tend to be more supervised. It's so hard to act on suicidal thoughts, and maybe unable to carry out any kind of complicated plan for suicide if it's a more advanced dementia. It might be as mechanical as that. But nonetheless, it's important to recognize that 60% of people with dementia in the US, 60% of people with diagnosed dementia live in a home with a firearm. And that number's been going up, partly because firearm ownership has been going up in the country, as we'll talk about in a second. I won't run out of time. And partly because of sort of the way that dementia care has been rolled out in this country. Sort of there's lots more in the home care, which is where the firearms are. And I think it's maybe common sense, but I'll mention that dementia is clearly a risk factor, not just for suicide, but also for other dangerous firearm consequences like accidents. I had a patient back when I was a resident, an older guy who had actually previously been a fire chief. He was a really great guy. He was a wonderful guy. But he had Lewy body dementia, which is a sort of a dementia where you'll sometimes sort of have visual hallucinations. And he'd woken up in the middle of the night and he thought that there were small men, like Lilliputian men, crawling all over his wife's legs next to him in bed. He thought they were tying her up, like in Gulliver's Travels or something. And so, as any protective husband would do, seeing this, he reached into his bedside drawer and he got his gun. He started trying to shoot the men off of her legs and, shot her in the legs multiple times. She actually did very well. She didn't lose the use of her legs, but obviously he was incredibly distraught, right? Like when he was more, with it. He can't believe he shot his wife, and just like at that, I remember having a conversation with him being like, I think it's time to not have a gun in the bedside drawer now because, you can't trust your senses now. But it's amazing how people with dementia do have these. I'm gonna skip over this because I want to get to some other things. I will mention this idea of a advanced firearm directive. This is an interesting idea that comes out of the VA and also from some excellent docs like Emmy Betts in Colorado. This idea that it's maybe a good idea for people that are getting older, especially after a dementia diagnosis, to make sort of a, not legally binding, but sort of informal agreement with family or with their doctor or with their residents about when they're going to maybe not be allowed to have access to their firearm. I know this is a progressive condition. At some point, I'm not going to really have the faculties to be someone who can own a firearm. I need to just have someone external to decide when it's okay, like my daughter, my wife, my roommate, to say, okay, you know what? Remember we had this agreement. I think you've gotten to the point that the firearm needs to leave. The same way as is done in many places for driver's licenses. Sorry, my pop-ups on my screen. You know what? I'm going to skip over this just to say there's been a dramatic increase in gun ownership. It's especially new gun owners. I'm going to skip over this just to say that there's been so many new guns in this country since 2020, an unprecedented number of sales every month over month. That suicide rate I mentioned before. Remember I said that this past year was the single highest increase in suicides that we've ever seen in any given year in the U.S. That suicide rate was only firearm suicides. Gun suicides went up 10% from 2019 to 2021. Non-gun suicides actually dropped 8%. It was really just the gun suicide. So skip over some of this stuff. I do want to just mention that there are lots of ways to store guns safely in the home and out of the home. I use this table from Megan Ranney They're just sort of like, I use this with patients sometimes saying, look, here are some options you might use. Cable locks are very cheap, but they're not the best. I mean, you can get through them fairly easily if you really want to. But they do put a little bit of a barrier, just like that bubble wrap on the paracetamol. This table says cable locks are $10 to $50. They're not actually. They're like $5. I don't know. You can actually get them free from Project Child Safe, from the Rocky Mountain VA in Colorado, will ship them to you. And most gun stores give out a cable lock when you buy a gun. You often see them in the trash cans outside gun stores. So they're easy to get. Going up to like, trigger locks, lock boxes, safes, especially those fancy like fingerprint activated safes. They're very expensive, but they're really effective. And then there's the idea of recommending, if you have a resident who's in a crisis, like they're in a depressive episode, that kind of thing. They maybe just had a dementia diagnosis, for instance. Maybe it's a good idea to store that gun outside of the house for a while, store it with a family member, store it with law enforcement. A lot of shooting ranges, gun stores, and pawn shops will hold on to someone's gun temporarily for them during a crisis, although it's legally a little bit gray, especially in background check states. A lot of states, like Maryland, I linked here to Maryland's safe storage map. A lot of states like Maryland and Washington State and New York and Colorado and Ohio have safe storage maps. You can Google area, like places in your city or your state where there are pawn shops or shooting ranges or police stations that are willing to hold on to a gun temporarily, kind of no questions asked in crisis periods. Now, finally, I just want to talk in the last little bit here about red flag laws, which is something I'm very excited about as a way to reduce suicide. For those not familiar with red flag laws, which are called different things in different states, these are laws that allow police or family members to petition a court to remove firearms from individuals who might be a risk themselves or others temporarily, right? So Connecticut started with these in '99, but really other states came on board in 2018 after the Parkland shooting. Maryland was one of the states that came on board in 2018, as well as about 18 other states, and then more have trickled in. And now 21 states and DC have ERPO laws, extreme risk protection order laws, gun violence protective order laws. They're all red flag laws. You can look for your state on this map here to see if you have one. And many more states have them in the legislature right now that might pass. The only state I can say confidently won't have one anytime soon is Oklahoma, where they've actually passed a law making it illegal to propose a red flag. But other states, these are really powerful tools. In fact, Jeff Swanson down at Duke did a study of these laws back when Connecticut was the only one that had them, and found that for every 10 or 11 guns seized by a red flag law, one firearm suicide was prevented. He followed up. Other groups, Aaron Kavisto and Peter Fallon, did a study of Indiana's version of the law and found that just passing the law led to a reduction in firearm suicides by 7.5%. They continued for 10 years. They had an early version of the law without any increase in suicides by other means. Of course, these are passed to prevent mass shootings. And Garen Wintemute had this study I mentioned here that said that they do really prevent a lot of mass shootings. But because the majority of gun deaths in the US are suicides, that's where we're seeing the impact the most in preventing suicide. So we'll talk about Maryland's law just because it's one example. They're all pretty similar across states. Maryland's law, though, was the first to allow clinicians, social workers, nurses, doctors, healthcare workers of all sorts, to file instead of just police or family members. Other places also allow roommates. I believe Michigan's, which is about to come online, allows group home managers. They're different for different states, but here's how Maryland's law works. So you can file these red flag laws, or you as a residence home supervisor can ask a family member to file them. And what happens is a judge will either grant or not grant them right away without a hearing yet. There's just a temporary, quick approval if they think the reason you're filing is appropriate. Just like a domestic violence protection order, restraining order, it's just like that. And they file that law, and immediately the guns will be taken away from the person temporarily, and they'll also be put on the do not buy list, the NICS list, so they can't just go to a store and buy temporarily. In Maryland, and this is pretty much how it is in all the other states, within 7 days, there has to be a real hearing with the respondent, the person at risk, present. That's due process is a really important part of this law. Present to defend themselves. Say, no, I'm not at risk. Don't take away my gun. I need it because it's deer hunting season, or things like that. And there's a hearing, but if it's still granted, then it can be extended for up to a year. So those guns are held for up to a year. And in Maryland, it can be extended for a further 6 months, for a maximum of 18 months of having the guns taken. Let's see. Let's skip over this just to get to the summary so we have at least time for a little bit of questions. I'm sorry, I'm a little long. Just want to sort of summarize by saying suicide is a leading cause of death. The rates are rising, but it's preventable. It can be an impulsive act. People use what they have available, like I said. So if they use something like Tylenol, and which has a 98% survival rate, they'll tend to survive. And when they survive, they tend to keep surviving. As I said, only about 5% of people who survive a serious attempt go on to die later by suicide. But if what they have is lethal and they can access it like a gun or fentanyl, they're likely to die, and there's nothing to be done. Sort of a missed opportunity. In other places, those lethal means have been coal ovens or pesticides or Tylenol. But in the US, it's guns. That's what's been our major method of suicide, the vast majority of suicides. And so screening firearm access, regulating access to firearms, requiring safe storage in your residences, or generally decreasing prevalence are likely to save lives. In extreme situations, ERPOs can be used. Right. Sorry, I'm a little bit over. I meant to end with 10 minutes for questions, but we have about 4. Or I can stay on if you have. But thank you, everybody. I'm just thanking my collaborators here. Stop sharing so we can talk.
Thank you so much, Dr. Nestadt. It's so interesting to learn more about kind of the epidemiology behind this. We do have one question in the chat here. Why the increase in suicide for young kids that are being bullied? And then a note around possibly social media is egging it on. There is possibly more of a vulnerability in these kids. Just didn't see this when we were growing up.
Yeah, so I didn't focus on youth here just because of the audience, but I do a lot of work with youth. And I think you're right that social media is playing a major role. Actually, signed an NDA, so I can't talk about it, but I'm involved in a couple of class action lawsuits about social media that played a role in kids' suicides. I will say that there are positive parts of social media. A lot of kids find communities that accept them by having access to social media, and that can be really helpful. But yeah, cyberbullying. There's a great study that came out from Kira Ream, who was a PhD student of mine, where she tracked how much social media use there was and related it to internalizing and externalizing mental conditions and suicide. Actually, she used that paper to become the head of mental health policy for TikTok now. So she's able to actually affect the way that these things are working and make a lot more money than she would have stuck in academia. But yeah, no, it plays a major role. I will say, just to stay on topic for this talk, that the increase in youth suicide, and I didn't get into this here, but the 2 populations that went up the most in that that recent increase in suicide I mentioned was Black Americans and young Americans. Those are the 2 populations that went up the most. And in both of them, it was actually only firearm suicide. So young people, there actually has been a decrease in suicide by hanging, a decrease in suicide by overdose. Only the firearm suicides have gone up in young people, which might be driving it. And I will also mention that I said there was a big increase in COVID era gun ownership. That gun ownership was much more likely to go up in younger families. So traditionally, when there's an increase in gun purchases, if these older white men who already have like 13 guns, they buy like the 15th or whatever. But these were mostly new gun owners, and they were buying them, and they were less likely to store them safely because they're less experienced. A lot of gun owners are responsible. They know they got to store the gun safely. These were new gun owners, and they didn't. And this was during a time, 2020, 2021, when having kids in the house meant those kids were really in the house. I have an 8 and 10-year-old. So those of you that have young kids know that during 2020, Zoom school, those kids were stuck in the house, and they had nothing to do. I mean, they had Zoom school, but they had nothing really to do. And they were exploring. They were like going to every cabinet. I'm sure that there was an increase in youth liquor use as they found ways to get into our cabinets. But they were exploring in these newly armed houses. And that might have been part of why there was an increase in youth suicide, specifically in kids that might have otherwise had those negative thoughts and attempted in some less fatal way and then gotten help, ended up dead, unfortunately. But there's lots of factors.
I wanted to thank you too for your presentation. I know we're right at 1 o'clock, but I was just going to mention I part-time on the weekends am a mobile crisis social worker in Cincinnati. And I wish I could say that we would be able to pass a red flag law in Ohio, but I don't see that happening anytime soon. But our mobile crisis team does have, we just got those cable locks and from the VA and everything. And so just so that you all know that if there is a mobile crisis team close to you, they may be able to share those with you, or, just know that they're a resource, that they have them available and they're free to give out in the community too.
That's great. And I like those ones from the VA because they actually have suicide crisis numbers there in the package, right? That's really cool. You can also get them free from basically any law enforcement agency. There's a partnership between the National Shooting Sports Association and basically law enforcement, where they provide these, they're called Project Child Safe locks. If you go to Project Child Safe, just Google Project Child Safe, find your state, your county, your police department, reach out to them. They get free gun locks. They just get distributed through the police to citizens. Another resource. In Maryland, we actually have our Department of Mental Health printed out our own sort of little crisis number on all of our cable locks and can give those out too. But it's a good resource, and mobile crisis in general.
Thank you so much.
I can answer more questions people have, because I don't have to have another talk at 1:30, but I'm free now if people have questions on this.
That's very generous of you. Are there other questions from folks who are still on with us? I had a question, Dr. Nestadt, just thinking about in Maryland, we have the new suicide prevention hotline. And I'm wondering, are you or is anyone doing research around what effect that might have in the state? And I know some other states have them as well. So just curious.
Yeah, so there's been suicide crisis hotlines forever. There's been a national hotline. In Maryland, we used to have 211, press 1, 2. Now we have 988. 988 is federal, so every state has 988. You can call 988. I will admit, although I'm a big supporter of 988, there is no data to show that it actually decreases suicide rates directly because of privacy. We can't track people. We don't want to track people. We want to be anonymous, so we don't have that data. Doesn't mean there's not an effect, but I unfortunately can't say, well, here's how much it helps. I will say that one of the most important things that does happen when you call 988 is, by the way, the way 988 works is it depends on where you're calling from. So if you call 988, it'll connect you theoretically to your local crisis response center. So in Baltimore here, if you call 988, it connects you to BCRI, who doesn't run mobile crisis basically. They'll talk to people, but they can also send a mobile crisis team. They can also make recommendations of therapists in your area that have openings, depending on the level of severity, et cetera. It's really effective, especially for getting care. So I think it's a really important thing. I always encourage people to call 988. But I will also say, and this is maybe too in the weeds, but if I say to patients, if you're really in crisis, like it's really acute, like you don't know what you're going to do in the next 5 minutes, call 911 instead. And the reason for that is that depending on your location, 988 can't use geolocation as well as 911 can. There's maybe two in the weeds, but like 988 uses the first 6 digits of your phone number to guess where you are. But of course, many of us have phone numbers that don't relate to our. Whereas 911 uses cell phone tower geo triangulation over my head. But they know exactly where you are. They can activate your phone. Now 988 can invoke. They can invoke the 911 services. I talk to these operators. There's a delay. It takes a while. Sometimes they can't even get a hold of them. So if the real crisis 911, if you've got 988, is great. And of course, having a safety plan, which we didn't talk about today because there's only so much, should always include 988 as one of the things to go to.
That's really helpful. I guess one other question, just knowing who's on the call with us today and who might go looking for this recording afterwards. For folks who are not in a clinical position, but are working with older adults in these affordable senior housing communities, are there, things that you would encourage folks to be on the lookout for with residents? Or if someone is maybe talking about harming themselves,
That's a great.
What can folks do?
So I gave that list of some risk factors for older people, but I think to really highlight what I think is most relevant, changes in behavior. Someone that had been very social and outgoing but suddenly isn't, it's always an issue, can indicate sort of substance use, or the worst thing of substance use, but also can be a depressive episode. I really want to emphasize that psychiatric illness is maybe the most important risk factor. So the sort of things you look out there. So, it depends on the relationship you have with a person. You might hear from other people they become more isolated lately. They stop going to their appointments. I don't know if you're ever in touch with their actual mental health providers who might be able to say, hey, I'm worried about this person right now, that kind of thing. But tends to be self-esteem issue. Like if you're actually talking to them, things like self-esteem, energy level, and mood are the 3 things I care about the most when I'm assessing for a depressive episode. more so than things like than changes in appetite, which are other risk factors. Sleep changes, which you might be more aware of being in their residences. Sleep changes, interestingly enough, when we talk about depression, the sort of superficial way of thinking of depression is there's 9 symptoms and you have to have 5 of them. It's a silly thing. But of the symptoms of depression, the ones that are most highly correlated to suicide are insomnia and anxiety. Those are ones to watch out for the most for suicide risk. Not necessarily intuitive, but those are the ones. Even more so than suicidal ideation, interestingly. So a patient that reports suicidal ideation isn't as much at increased risk as someone who, for instance, can't sleep. Weird. Suicidal ideation is what we base most of our clinical work on, and the data behind it is not great. But if someone does report suicidal thoughts, the best thing you can do is get them into care. And it's also maybe important to note, it's never a bad idea to ask someone if they're having suicidal thoughts. People sometimes have this idea like, well, I don't want to plant that idea in their head as if they're that malleable. That's not the case. If you ask someone directly, whether they're honest with you at the moment or not, you've told them that you're someone they can tell if they do have those thoughts when they're ready to tell you. They might not be open at that moment, but you've said this, I'm sleeping. And you can ask it very directly. Like, it sounds like you've been going through a lot. Have you had any thoughts about killing yourself? Have you had any suicidal thoughts? That kind of thing. People tend to beat around the bush, and it doesn't do anyone any favors. Ask them directly is the way to go.
That's really helpful. Thank you. We so appreciate your time today, Dr. Nestadt. And would you be willing to share, if not your slides, a brief kind of summary of some of the key data points that you talked about? Maybe that last summary slide.
Yeah, actually, my slides are probably easier to share than summarizing. Is it okay if I just say the slides? All right.
Yeah,
cool.
that would be great if folks want to go back and reference things. And we'd love to have you back again sometime.
All right. Thanks a lot. Great to see you.
Thank you, everyone. Take care.